Fractures, Pearls, and Pitfalls by Dr. Simon Kelly.
Great. Thank you very much. Happy to come and crash the upper limb party with this one. Okay, so the talk today, we're going to discuss some acute fracture management principles, but I'm also going to go through my simplified approach about how we deal with the common and very challenging issue of the dreaded growth arrest. Now, I know we're getting towards the end of the session, so from my talk, I just want you to remember 3 words: stop, straighten, and stretch. More about that later. So for the non-displaced fracture, 6 weeks in a long leg cast will usually suffice. Most of these fractures are displaced, and so we prefer a closed reduction and percutaneous pinning. So in a Salter-Harris 1 or a Salter-Harris 2 without a metaphyseal or significant metaphyseal fragment, then percutaneous smooth K-wires across the physis removed at 6 weeks for ideal. When we have a larger metaphyseal fragment, then 1 or 2 percutaneous cannulated screws are ideal. And sometimes the fractures are irreducible. It's usually because there's a piece of periosteum that's flipped inside the physeal separation. So what we do here is make a small incision opposite the metaphyseal fragment, flip out the periosteum, reduce the fracture, and pin it back together. So surgery on the whole is usually pretty straightforward, but excellent surgery does not guarantee excellent results. And this is why I'm going to give you a simplified approach to managing that dreaded complication of the growth arrest. So growth arrest is really common. It occurs in up to 50% of these injuries, and it happens regardless of the fracture pattern, although there is some variance. It also happens regardless of the reduction and stable fixation, and even in undisplaced fractures, growth arrest occurs in up to 30% of cases. So you've got to watch for this in every single case. And why is it important? Well, it's important because prevention is better than cure. It's easier to prevent a limb length discrepancy than lengthen a limb. It's easier to prevent a deformity than perform a corrective osteotomy. And if you do have to lengthen a limb, it's easier to lengthen a short straight limb than a short crooked one. The second issue here is this is a fast-growing physis and deformity occurs very rapidly. So if you're not alert to the signs and you hesitate on making the diagnosis, suddenly you have a deformity and then you've got a much more complicated situation to deal with. So why does it get difficult? Well, let's consider the goals here. We want to prevent deformity, we want to prevent limb length discrepancy, and if possible, we want to re-establish growth, a combination of the 3. And then we add in the patient factors, the sex, any existing limb length discrepancy, their age, growth potential, any current deformity, and then add on top of that all of the tools at our disposal. We've got epiphysedesis and bar resection and nails and osteotomies, and you have all of these variables and all of these different treatment options, which is why I just want to offer to you today a very simplified approach to managing a growth arrest, which is stop, straighten, stretch. So stop. We're going to stop the limb length discrepancy from occurring, we're going to stop the deformity from occurring, or stop it from getting worse. And we can do that using, for example, an epiphysedesis or a bar resection. Step 2, straighten. So we're going to correct any deformity that's occurred, so perhaps with an osteotomy or in some situations using guided growth. And then step 3, stretch. So we're going to equalize the limb lengths, typically with a limb lengthening procedure, or sometimes with a delayed epiphysedesis. But of course, we don't have to do 3 separate surgeries. We can combine these in any manner that we choose. So we could perform surgery 1 to stop, surgery 2, straighten and stretch together. Or we can stop and straighten together for surgery 1, and then stretch with surgery 2, or we can combine all 3 in a single comprehensive plan. So let's see how this works. So here is a 12-year-old girl with 2 years of growth remaining. So I decided to stop and straighten as the index procedure. So that's a bilateral epiphysedesis, an acute corrective deformity. And then stretch, well, we didn't need it because that turned out to be the definitive treatment and she did pretty nicely. Or consider this case, a 9-year-old boy with 7 years of growth remaining. So I decided to do stop first, isolated procedure, a unilateral epiphysedesis. Straighten, well, we didn't need to straighten because, of course, we prevented the deformity from occurring. But, of course, now he has a limb length discrepancy, so that's where stretch comes in at the end, using a telescopic nail to perform a limb lengthening, and again, he did very nicely. But, of course, this strategy doesn't just work for distal femoral physeal fractures. This will work for any post-traumatic growth arrest that you come across in your practice. So if you just remember these 3 simple words to stop, straighten and stretch, you'll have a simplified and pragmatic approach to this most common and terrible of complications. Thanks very much.